All right. Can you see my screen?
Yes, we can see your screen.
Yes, thank you. All right,
It's full
so
screen now.
yes, great. Okay, there are still some people arriving, but I think they will catch up on the way.
I will,
Yes,
admit all of them. You can
thank you.
continue.
So today we will talk about developmental, supportive, and family-centered care. Starting with some basic key messages about the subject. Environmental factors within SNCU can be very stressful for the developing neonate, for the developing brain of neonate. And there are simple and low-cost actions that have an immediate and lifelong support and impact on those babies. Especially preterm infants, those they are born during critical periods of brain development, and everything that happens to them from birth, everything that happens to them in the NICU has an impact in their future, in their development. Terms and near-term infants, they are also at risk of adverse developmental outcomes, especially those that are more sick, those who are surgical, those who spend more time in the NICU. So these are also subjects of developmental supportive care. Infants and family-centered developmental care promotes basically a healthy brain development through individualized neurodevelopment and supportive care. So just starting with this baby, it's the same baby in both pictures, but the baby is in two different situations. And I would like you to observe this baby, and you can write in the chat, what are the observations you have in the first one, which is this one that I have my cursor on, and in the second one. So basically, what's the story? What do you see on this baby? And this is the baby. This baby doesn't have much difference from. It's basically a few hours difference. There is no change in the clinical aspect per se, but something changed, and I would like you to make the observation of what's different. So you can write in the chat. My voice is low. I think I heard that. Can you hear me well? Or
I can hear you well, Flavia. I think
yes,
it's
okay.
good.
Okay. So I'll leave you with your observations. I just saw someone who said that baby 2 is nested, which is true. There are some comments about the nesting of the baby 2. Baby 2 is the same baby as baby 1. Huh? And it's just, we arrived and there's something that was done to this baby when the baby was in this condition, and the baby's condition is this actual condition, basically. So you can put your comments there, and I will follow that, and we are going to do these observations again when we arrive to the end of the presentation. So just some background, the survival of the term and preterm infants has improved significantly in the past years, the past 10 years at least. Neonatal mortality is still high, especially preterm mortality, but the more mortality decreases, the more we think about the future of these babies, because we don't want them just to survive. We want them to survive in the best possible condition. And basically, this is the objective of any person who is working, any professional that's working with neonates. We want these babies to survive and thrive. We want them to reach the best potential that they could reach. And basically, long-term neurodevelopment consequences, they are very, very important to these babies. The risks, they include neurodevelopmental delay, cognitive impairment. They can also have behavioral problems, hearing and visual impairment, which are sensorial complications that are very common in preterm neonates. The third trimester is a period of rapid brain growth. So even for a baby that's born term, there is a rapid brain growth after birth. In the first 2 years, there is an explosion of neuronal growth and synaptic activity. But for a preterm that is born before this period of rapid brain growth, it's even more important, because these babies, they are going to have their a large part of their brain development that's going to happen outside of their womb. So for these babies, it's still even more important what happens to them, because everything will affect basically their brain growth. So environmental stressors such as noise, light, handling may impact the developing brain of these babies. What is neonatal and family-centered developmental care? It's a framework founded on development, neurobehavior, parent and infant interaction, parental involvement, and environmental adaptation. We know that sensitive care is good for the brain, and parent engagement is good for the development. Individualized care gives every infant the voice and the better outcomes. And neonates, they have the right to have individualized care. They have the right to have a neonatal and family-centered developmental care. They deserve to be treated with respect. So what are the goals of the neurodevelopmental care? So first goal is to reduce infant stress responses. So stress is very bad for the brain. Stress affects brain development, and stress is very similar to pain. It's basically the same response that the baby will have in the brain, and continuous stress will affect the development. So we want to reduce that. And today we're going to talk about how to identify stress signs and stress responses. We also want to protect sleep. Sleep is an essential moment of the life course of a neonate. Neonates sleep a lot. They sleep most part of the day. And it's when they sleep, basically, that they assimilate everything that they learned, and the brain develops more during sleep. Everything is organized during sleep. So sleep is extremely important for development and also for growth. We want to support. So we want to support caregiver cognition and behavioral cues. So we want to support mothers that are giving care, that are primary caregivers, and we want to support caregivers that are health workers to recognize what babies are doing, when they need support, when they are stressed, what are the changes in behavior they need an intervention, or what are the behaviors that are not supposed to be touched. We want to conserve energy and optimize growth. The best status of a neonate is when the resting expenditure is basically neutral. So we don't want neonates to spend their energy with stress or with thermoregulation or with any other circumstance. So we want to conserve this energy because energy is important for growth, and we want these babies to grow in the third trimester, especially for preterms. So the third trimester is where you have a larger amount of growth during the pregnancy. So it's very important that these babies, they grow to catch up, basically to follow their curve. And then they need to conserve energy to optimize growth. So we want also to support. So we want to support neurodevelopmental maturation. So everything that's said supports neurodevelopmental maturation, and there are other cues for that. And we want to encourage parents in the primary caregiver role. And we're going to talk more about that. So just going to go through some basic definitions of developmental care, behavior organization, and cue-based care. So because this keeps coming, so we are following the same language. So when you talk about developmental care, it's basically create an environment that minimizes stress and pain, of course, but just going in the same continuum of reducing stress and not only minimizing pain, but also preventing pain. We want to provide a developmentally appropriate experience that is individualized to each infant. Each baby is different. Even when you look at them, I heard so many times people saying that all preterms are the same, that you don't have to do many things different, you just do the same for everyone. And this is so not true. Every baby is different, and every baby in an EQ is at a different state. And we have to understand these babies and understand how to approach them and how to individualize their care. And then we support the infant and their family. And of course, there is no one better to understand their babies than their families, than their mothers and their fathers. They know they will spend more time with their babies more than any health professional. So they know their babies. They know how they feel what their baby feel. They can understand so much better. So they are the best people to help individualize the care of their babies, and they must be heard and supported. Interventions include optimal handling, also some positioning, reduction of noxious environment stimuli, and cue-based care, and of course, parent environment, which is major and very, very important, basically. So what's behavior organization? Behavior organization is just an ability to maintain a systemic balance. And this is very important. The examples, for example, are physiological status, the breathing rate, heart rate. Neonates, especially preterm, especially small preterms, just by touching them or by moving them. I'm sure most of you have already seen them. We touch them, their heart rate will change. And they will also change their breathing pattern. And the way we touch them, sometimes they will have an apnea. And by touching progressively, we see the changes in their posture, they will react to what you're doing. And it's not just like a bigger baby, a full-term baby or an older child. It's much easier to understand their response. In a preterm baby, sometimes the response is going to be very subtle. It's going to be a change in the posture, sometimes just a difference in the facial expression, which is difficult to see, for example, when you have a baby on CPAP, and have just to understand how to see that. We also see differences in colors. A baby can become mottled or basically just pale. Visceral responses, babies can vomit or can start to have hiccups or can spit. And visual attention. Baby can change completely the regard. The baby that's very attentive, by touching the baby in the wrong way, by approaching the baby in the wrong way, he will basically completely change his focus. So learning how to see these things is basically part of our buckle. That's like a feedback buckle. We will observe, we will respond to it, and we'll change what we are doing to support the baby. So then we enter in what we call cue-based care. So basically, cue-based care is this individualized caregiving that is responsible to the behavior of the baby. So this modifies sensory stimulation. This basically modifies sensory stimulation in accordance to what the baby can tolerate. And the care is guided by clinical stability, by the maturity of the baby. Of course, a preterm, a very, very small baby that is unstable, you're going to have a different way of caring for the baby than for a bigger baby that's a full term or a late preterm that is more stable, that it doesn't need much support. So depending on the baby stage, the care must be adapted. So this is just a small figure. It's a guide that we have, and it's in French. I'm sorry for that, but it's just to talk about the sleep. I have a video after that is going to go a little bit further on that. But in this first figure, we have a baby that is sleeping deeply. In the second one, we have a baby that is in light sleep. And in the third figure, we have a baby that is awake and alert. So this is to talk about what we do to a baby that it's sleeping deep sleep. So many times some people, they will just, it's time for cares. They will go and they will wake up the baby. So this is something really to avoid, to wake up a baby that is in deep sleep. It's very, very stimulating. It can be, it could be traumatic actually to the baby. Whereas a baby that is calm, it's vigilant, is ready for cares, and even maybe ready for some oral stimulation, for some feeding, for some non-nutritive suckling. So this is the baby that's ready to receive information. Every touch, everything that we do to a baby is basically new information. It's information that the baby will assimilate. And the baby can assimilate the information in the good way when the approach is done in the right way to minimize stress and to give support, or the baby can receive the information in the wrong way when the information is stressful, for example, waking up a baby. And below here, we have a baby that's awake, but it's very agitated, that's crying. So this baby is also not ready to be moved or to be changed. Also the baby here that is agitated. And this one here is in retreat. Basically, sometimes a baby will not cry, especially the small ones. They will just close themselves. And these are also not the best moments to approach them, to propose new things, or to keep changing them from position, etc. So these are the moments to bring back some support, to contain them, and to stabilize them before starting something else. And we are going to see this a little bit more further, but this is just one point on look at the baby before And the best moment to approach a baby is when the baby is awake and vigilant. And babies that are agitated or babies that are in completely deep sleep, they are not ready to be approached unless if it's a baby that's agitated, of course, containment, KMC, do things that will basically stabilize this baby. Okay, so how to implement developmental care? So first thing is to observe behavior of the baby and physiological cues. Of course, a baby that's having hiccups, a baby that's sneezing, that's agitated, that it's completely pale and having apneas or unstable hemodynamically, this baby is not ready to be manipulated in a more vigorous way, for example. So just have to see what the baby will accept and what the baby will tolerate. And basically, based on what we are observing on this baby, we will approach with the best care. And we modify the care according to infant's condition. So some babies, they can have cares every 3 hours. Some babies, they will have care less often. Some babies, they will need to have small cares that are more often than larger cares that are very often, depending on the condition and what the baby will tolerate, basically. And this needs to be regularly assessed. And basically, again, it's not only the moment that the care starts, it's all the feedback loop. Everything that we do to a baby, the baby will have a reaction, and we have to look at the baby and see what's the reaction and go back to either supporting the baby, either continuing the action. So we have also to adapt sound, light, and the nursery environment, basically, to babies. And we see a little bit more of that. So what are the nurturing practices that we go through? Parental involvement, positioning, providing cluster cares, sleep protection, stressful and painful procedures, feeding support, staffing practice, touch, and KMC. KMC is very large here, and you'll see why. So parental involvement starts even before birth in the continuum of care. A lady that's going to have a preterm baby needs to have counseling whenever possible before the delivery happens. And so she will be ready to receive her baby. And then when the baby is born, she should be able to see her baby, and she should be able to touch her baby as soon as possible. She should be able to have a skin-to-skin care in the delivery room, if possible. And this should go in the continuous. They should be able to go to the NICU and visit their baby, and they should be able to be involved in patient care in a way that at a certain point, parents, they can be even independent, practicing cares for their own baby. As you can see in this picture, it's a 26-weeker that has just a few weeks, a couple of weeks of life, and on CPAP, and the parents, they are providing care. They do provide KMC, but when they're not providing KMC, it's the baby cares time. They also help with the cares, and it's just mom and dad there that they are providing cares for their baby. So this improves basically the brain development, and it also improves the psychological well-being of the babies, promotes parent and infant bonding, increases parental confidence, and also involvement of care. So many parents, all this separation makes the parents feel that they are not part of their baby's life, and that they don't have a role in their baby's care. So it's extremely important to involve parents, increase their confidence. And basically, the healthcare team should work with families and encourage the involvement of care. And of course, there is no better involvement of care than KMC. So this is WHO recommendation. This is the first recommendation, that family involvement in the routine care of the preterm or low birth weight infants in healthcare facilities is recommended. So we can see also here that the CDG noted that resources needed for the feasibility and implementing family involvement strategies vary according to setting, but that simple family involvement interventions such as delivery of direct bedside care and involvement in medical decision-making could be implemented in all settings. So this is not something that can be only implemented in high resources or in only when you have a lot of staff. On the opposite, parental involvement actually reduces the workload of the staff because they are active carers. So we made in this project, we made this DSC. So this DSC is for parents, of course, for health staff and for parents, but health staff can help parents understanding a little bit on what are the signs that they have to look for. So I think it's a little bit small here, but I will read. So in the beginning, we have babies, especially small preterm babies. They cannot talk, but they do communicate through their body movements, face, breathing, and behavior. Recognizing these signs help the parents, help you know when the baby needs a break, comfort, or support. What are stress signs? So stress signs are signals that your baby feels overwhelmed, tired, uncomfortable, or needs a pause. This is normal. Babies are still learning how to adjust to the world. So the common stress signs to look for, so we just have a list of common stress signs so we can teach this to the parents. For the body and movement, hands is spread open like a stop sign, like this, like we see this baby here. Sudden jerky movements, stiffy arms or legs, like you see this baby here, arching of the back, become very floppy or tired. So this is very easy to recognize. What many people don't recognize is when a baby becomes very floppy or tired. So sometimes the baby was moving a little bit, and then you start to do an intervention, the baby is completely floppy. And this is already a sign of stress. It's just that the baby, that's the way the baby is responding. The baby cannot say, this baby is weak. This baby is not able to say stop. Is not able to cry loud. And basically the baby's response is the floppiness. In the face, we can see frowning or grimacing, crying or fussing, and also looking away or avoiding eye contact. We can also see differences in breathing and color, so fast, slow, irregular breathing, pauses in breathing, or becoming pale, bluish, or very red. Other signs are hiccups, yawns, sneezes. Sometimes people are, oh, the baby's sneezing, or the baby's yawning, the baby wants to sleep, but actually this is the destimulation sign. It's a stress sign. Difficult settling, changes on the monitor, so increased heart rate, apneas, increased respiratory rate, and all of these responses to stress. So how can you help? Basically pause the activity, give baby time to settle, provide containment, which is in this picture, you see a little bit further, provide, which is holding the baby with a curled, secure posture. Offer skin-to-skin contact. So KMC is really the best for any of these situations. Reduce noise and light. Speak softly and move slowly. So again, the way we speak to the babies is very important, and the way we move through the cares is very important. So we speak softly, move slowly, and let the nurse doctor know that this is the parent, that you feel that there is something wrong. So how do you know the baby is better? The baby will show the self-calming signs as hands are near to the mouth. So you can see when the baby is doing this, the baby is open basically to learn, baby is touching their own face. It's a very good sign. Sucking movements, relaxed face, smooth, calm breathing, snuggling into their own chest during KMC. And these signs, basically, the baby's doing like this. These signs basically mean that the baby feels safe and comfortable. And then we have another message here for staff, but also for family. Family, sometimes they don't know that. Many times they don't know, but they should know that the family presence during hospital stay is fundamental for the baby growth and development. Another recommendation is that families of preterm or low birth weight infants should be given extra support to care of their infants, starting in healthcare facilities from birth and continue during follow-up discharge. This support may include education, counseling, and discharge preparation for health workers and peer support. So concerning education and counseling, we have prepared all these IECs, so we cannot see very well here. We have already been through those. So IEC for danger signs. We have this one is basically to use when the babies leave the facility, to explain to parents how to recognize danger signs. This one is on feeding, mothers on milk. And this one is the one on KMC. Of course, always hand hygiene is fundamental. And we also providing the parent counseling guide on KMC to all the facilities. So let's go to the positioning. So we talk about positioning the baby, positioning the baby reduces stress. So basically promoting a flexed and a contained posture of the baby does reduce stress and reduce energy expenditure. Also put how it's called the nesting, as we can see in these figures here, reduces, not only reduces stress, but also gives them an environment that is very close to the womb. They basically reach their posture that they have in the womb. It's also very important to encourage hands to mouth for self-surfing, so not arms extended. So encourage arms that are folded, and it's ideally to have some support so they can basically move their hands around their face. Maintain neutral head and neck alignment, very important, that the head is in the same alignment of the body. This is very important also for blood flow to the brain, basically. Just by disaligning them, reduces very importantly the blood flow. Swaddling and nestling appropriately. So swaddling can be done, especially if you don't need to monitor the baby, if you don't need to monitor the respiratory rate, if it's a baby that's more stable, if you're going to do a procedure. But be careful with swaddling. Many people swaddle a baby that in a very tight swaddling. So swaddling needs to give space for the baby to move their legs, to move their limbs, basically, and to just be supported below the swaddling. But they do need to move. Movement is extremely important to development, and we want babies to move. Variations of supine, prone, and sideline positions are also very interesting, so that the baby is not always in the same position. So this is in the job aid, and basically this is a sideline. These are do's and don'ts. Sideline lateral position, that's basically baby can touch his own face, and prevents retraction of shoulders and abduction, basically, of legs, which we don't want. A prone position, that can also be done. So this can be alternated, basically, especially for babies in respiratory distress that are monitored. Basically, this improves oxygenation. It also reduces heat loss and energy consumption. This is a supine position with nesting, but it's just slightly asymmetric, which is good because then the baby can basically move the arms. So we just don't want the baby to be like this. We want the baby to be able to reach their arms, and this movement, anti-gravity, is very difficult for small babies. So we want always to give some support. As you can see, the arm is supported here, so it's not falling behind. So the baby can still move the arm and touch their own face. So don't do what? This is supine position without nesting. So the baby has everything retracted, the shoulders retracted. This delay midline orientation and eye-mouth coordination. This is a continuous lateral position. So we can have this like here, side lying, lateral positions, but like asymmetric positions, not completely lateral and not continuous, because this can also cause a flattening of the head, and the baby is difficult for them to move their gaze. And extended position, this also to avoid. Inhibits flexion and basically impacts movement and function. So this is the baby that is completely impacted by gravity, basically. The baby cannot move against it. So we have here two different figures, and then we can see the difference of the babies. This baby has a nesting, but you can see that the position is not optimal, and we can see the difference here. So basically, what we want to know that the position is correct. So we want head and body in a straight line, arms flexed, bent in front of or near the body. So hands, they look relaxed with fingers that are softly flexed. The legs are flexed, and the feet, they are close together. The baby quiet, awake, or sleeping restfully, not looking stressed. And in the environment, we want an adequate support. So a nest that is not too flat, that is not too high, that is close enough to the baby to give support to the baby, but that also allows the baby to move. That's not just completely squeezing the baby. And again, this needs to be individualized to each baby. So we can see that this is reached in this position for this baby, whereas the baby here is completely flat with the arms extended, the head is falling behind, and basically this baby cannot move. So clustered cares, again, minimize handling, protect deep sleep. So we don't want to do cares on a baby that is on deep sleep. These reduce stress, and basically we can also group non-urgent tasks that are together, for example, changing a diaper and cleaning the mouth of the baby. We can do them together, and we can postpone if the baby is not well at that time. We can say, okay, we can do on the next cares, or changing an electrode that is still fine. We can also do everything that can be done safely on the next cares. But looking at the nose of the baby that is on CPAP, this is very important that it's done very regularly. So make sure that the nose doesn't have a lesion. So this needs to be done at each care. And the pause procedures if the infant becomes stressed, as we said before. So if the baby's on retreat, grimacing, you touch the baby's not avoiding looking at you, grimacing, and brings the limbs back to him, or the babies that goes completely an extension or an extreme extension of arms and legs. This baby needs a pause and needs containment, basically. So this is a small video. Just not sure if you can hear. Just a second. I think I have to share with sound. I haven't done that. Yeah. Okay. So this is a video from Ames that I think it's very good to have all this vision. Can you hear it?
Yes, Suman. Yes, sorry, Flavia.
Yes. Can you hear?
Yes, we can hear.
Okay, good.
Yes, we can hear.
In this video, we shall learn
Yes, we can
how
hear
to
you, ma'am.
assess pain and stress
Thank you.
in neonates admitted in the neonatal intensive care unit from the cues that they show. Behavioral states are behaviors that have similar characteristics and are central to understanding the newborn. The behavioral states indicates whether the preterm or sick infant is ready to interact with the environment or is fussy, needs to be calmed before any stimulation is given. Timings to the caregiving activities should be adjusted according to the behavioral states displayed by the infant. There are 6 behavioral states that are deep sleep, where there will not be any rapid eye movement and will have regular breathing. Second, the light sleep state. In light sleep state, they will have rapid eye movement and irregular motor movements. Third, the drowsy or semi-alert state. The infant's eyes may be closed or open and will have irregular motor movements. Fourth, the quiet alert state. In this state, infant will have bright look and minimum motor activity. Remember, this is the best time for giving stimulation. Active alert state will have eyes open, will have considerable motor activity and may look fussy. Sixth, that is crying state. Crying is the most common behavioral cue that indicates an infant's pain. There are, however, certain behavioral cues displayed by the infant which needs to be carefully observed and respected. The physiological cues are change in heart rate, respiratory rate, oxygen saturation level, color, tremors, and twitching. The visceral signs are hiccups, coughing, spitting, or drooling while feeding or vomiting. The motor cues are arching, fingers play, foot's play, sitting on air, high arm guard, startle, salute, fisting, rolling eyes up, averting gaze, gaping, being fussy, grimacing, or frowning. These cues are indicators that the infant is overstimulated. The activity should be stopped and calmed before the activity is continued. Observing an infant over a period of time is crucial.
I think that's it. And you see this baby, the mom, she's very happy with the baby, and she doesn't understand that her baby is showing signs of stress. The hands, the feet, the basically baby is showing many signs of stress with the hands opening and the arms extended, also the legs extended in the sitting position. But well, she hasn't been told about it, right? So a baby like this, it would be ideal for her. She's there. Just put the baby on KMC. That would be the best thing to do, or give some containment if there is any care that needs to be done. So pain and stress. We basically need to minimize painful procedures in the NICU. Regular pain assessment is important for babies, and also not only minimize pain procedures or thinking about pain when the pain is there, but also thinking about preventing pain. And everything that you're talking about, positioning, about KMC, about all the way that we are approaching the baby, reading the baby cues, is a way of minimizing pain and stress. But sometimes it's there. NICU is a stressful environment, and there are things that cannot be avoided, but they can be minimized. For example, when we do a painful procedure, it can be done on KMC. That's what's happening with the baby here. And there are other ways of doing that for non-pharmacological pain management. And well, when pharmacological pain management needs to be done, also needs to be done. So for that, we have the job aid for pain. So in this job aid, we have basically first an introduction that newborns, especially preterms, they experience pain more intensively, and they have limited capacity to modulate pain. Repeated pain does affect brain development, sleep, feeding, and physiology. And then we have minimization for procedural pain, which is non-pharmacological, and a list of what to do and when to do. So KMC, skin-to-skin contact, provides warm physiological stability and significant pain relief. So when to use KMC? So KMC can be used in all minor painful procedures, heel prick, IV insertion, NG tube, suctioning. So basically, all minor painful procedures, most of procedures can be done on KMC, and it does minimize pain and stress to the baby. So it's very good. Also, breastfeeding and express breast milk, EBM, mother's own milk. So suckling, basically, sucking and breast milk components do reduce pain response, and they do provide bonding. So basically, we can give EBM, can give up to 2 meals orally, and even small babies, they can receive small amounts of EBM before procedures, ideally 2 minutes. Ideally 2 minutes before procedure. And we wait for the procedure to happen after. So could you please put the microphone off? I don't know who is it. I think, okay. And going back to the breastfeeding. So mild to moderate procedures, mild to moderate procedural pain, for example, heel prick, IV insertion, NG tube, other minor procedures. So for example, we can even combine them. We can combine breastfeeding or express breast milk with KMC before procedural pain, for procedural pain. And it's gonna have an even better impact. Also, non-nutritive sucking. So non-nutritive sucking, again, for babies that cannot, don't perform suction, actively suction, but basically enhance analgesia, and specifically when combined with EBM, and even babies that do perform suction. So we can go with small amounts of milk and give for this baby to suck EBM, or we can use a small cotton pad. I'm going to show it to you in the figure, just being careful with that. There are different techniques in different units. Just be careful. Some people, in the past, they used to use a glove with cotton inside. This can be more dangerous, so it's not recommended to do that. Facilitated tucking containment. So containment is very good. So containment, as you saw in the picture, just by containing the baby. So every time that you do a procedure, one person will contain the baby. And then, for example, we can combine again. If the baby cannot be on KMC, we can do some suction and containment, and the other person will change the NG tube or do the procedure. Swaddling. So swaddling is very, very also affected. So we wrap the baby snugly, but it's still having some space to do some movement below the covers in the midline posture, and this decrease environmental stress. So this can be done before procedures if the procedure is not done in the area that is swaddled, of course, and also it's if you don't need to monitor the baby visually when you are doing the procedure. Environmental control. So environmental control reduce noise, light, and basically the handling to support self-regulation. So even if you are not doing a procedure, or if it's just before cares, just to have an environment that is controlled before cares will let your baby accept better all the stimulation that you'll be doing during cares, basically, because the baby will not be so tired and so destimulated already when the care is happening. So this is when pain is there. How do I identify? So we have proposed this. There are several facial codings that exist. So we have proposed this one, pain assessment score. We have a score that goes from 0 to 4, basically. We can look at the brow bulge. So this is a common sign, the eye squeeze, nasolabial furrow, basically, and the open lips. If the baby has one of each of these signs, it's 1 point. And if you have 2 or more, means the baby is praying and requiring treatment, which can be, again, one of these non-pharmacological treatment. If the baby is responding, that's perfect. 1 or more of this pharmacological treatment. Or if the baby doesn't respond, of course, we need to identify what's the cause of pain. If it's a procedure, we know. Once we know the cause of pain and the baby didn't respond to a non-pharmacological procedure, to a non-pharmacological measure, we can also give paracetamol. Paracetamol can be done, and we have the doses here. So sleep protection. So sleep is critical for the brain development. Sleep deprivation may affect growth and neurodevelopment. So we need to protect quiet sleep whenever it's possible and reduce unnecessary stimulation during sleep. So baby is sleeping, we don't touch the incubator, we minimize the noise around the baby, we don't put highlights on the baby. We basically create an environment so the baby can sleep well and rest well and have their brain assimilate the best of the information.
T'es tout accroché à mon doigt.
So this is a video. I'll just pause and I'll put it back. So of nutritional support. So nutritional support is key to neurodevelopment. So feeding should be infant-led and cue-based. Again, when you start feeding a baby, so this is a very preterm baby, that is the start feeding, and this baby cannot suckle in the breast, in the breast yet. We do non-nutritive feeding in the breast, which is amazing. But when the mom is not there, or if you're doing a procedure, you can also give some small amounts of milk for the baby to have an oral experience, to have this tasting experience, which is extremely important for orality, for the development of orality, and it will help the baby basically to reach, to go through basically the feeding process and reach full feeds faster. So, of course, support breastfeeding whenever possible, and whenever possible, we encourage also non-nutritive sucking, which they're doing in the video right now, and you see the baby is awake and alert and really ready to receive it. It's in French. Sorry about that. See, but she talks to the baby.
Bravo.
She says, "You're doing well, bravo."
Ah ouais, t'en as marre?
She does some stimulation on the side. So this is to stimulate the reflex. So to see if the baby opens the mouth. And you see,
C'est reparti.
just by stimulating the
Superbe.
reflex, the baby starts sucking
Les
again.
petites mains sont bien en flexion.
The heads are flexed.
Oui,
The hands are
je
flexed.
me
You see, this
concentre.
one is very
Pas
flexed.
les petits bras en arrière.
She
là.
gives
Allez, mon
support
petit avec
to
les
the
fesses.
arm.
Ouais, superbe.
And then the baby wants to touch their own face now.
Bravo.
You see?
Ouais,
The baby
voilà, tu peux
touching
toucher
the
son
face,
visage
the
avec ta main.
mouth.
C'est très très bien.
And this, she's giving breast milk basically to the baby. So this is a positive experience for this
C'est tout
baby.
accroché à mon
If you have a baby that is tired, that is sleepy, and you shouldn't do this kind of things because the baby is not ready to receive that. And what happens basically is that the baby has a bad experience on feeding, and this can cause a neurality issue basically. It can basically have the opposite impact on the baby. It can be stressful and can be detrimental for feeding basically. Touch and handling. So positive touch promotes self-regulation. So use the voice before touch. So you saw that she was touching the baby, but she was talking to the baby before touching, and with a low voice, a quiet voice, like you talking to your own baby, basically. But talk to the baby, and you can just tell the baby, I'm going to do this to you, and this is what's going to happen. Just explain to the baby what's going to happen, and also encourage the parents to talk to the baby, to tell the baby what they are doing, what they did during the day, to read stories to the baby. This is very important also for sensorial development. And basically, this is just a baby that's being put on a KMC, and it's a baby that's on CPAP. And you can see that I just wanted to show how the baby is being moved. So this baby is still being moved. The baby is not yet in the final position, but you see she's holding the baby in a way that she's containing them. And they did the whole movement basically from the bed to the KMC, not just taking the baby like this. It was done by two people that were containing the baby through the whole processes, reading the baby's responses, and moving forward for the baby to have a positive experience. So moving the baby slow and contained, maintain flexed positioning, and individualized handling according to the tolerance. So when to touch a baby, how to touch a baby. So start with the feet, then move upwards, and then it can touch the abdomen. Always touch with the hands closed. So this kind of touching is stressful for the baby. So babies are supposed to be touched like this with containment. And hands upwards, and then you touch the head. So when you touch the baby before diaper change, during heel stick, before the cares, when moving positions, after or during an exam. So for doctors, it's very important. So medical exam is like the cares. When I talk about cares, when to touch a baby, it's also for doctors. They are not supposed to wake up a baby when the baby is sleeping, if the baby is stable. Of course, sometimes a baby is very sick and needs an immediate intervention. It's different. A baby in shock needs to be assessed. But I'm talking about a baby that's stable and that's sleeping. The baby will have to have clinical examination when they are awake and ready for receiving information. And also for the doctor, during the whole physical examination, they have to look at the baby and feel the experience they are giving to this baby.
You can do the analysis.
Yes, Mary?
Sorry. This is from the office. Sorry.
No worries. KMC. So basically, KMC does provide thermoregulation, physiologic stability, autonomic stability, reduces pain and stress, improves bonding, promotes breastfeeding, weight gain, reduces infection, hospital stay, and so much more. So KMC is the ultimate developmental supportive care. So the nursery sensory environment, just quickly going, we finished the part of developmental care, what we do to the baby, and let's think about the environment where we put our babies. So the recommended sound in a nursery is 45 to 50 decibels. If you look at this scale here, this is a 10 to 20, is the sound of a quiet forest. 35 decibels is the sound of a library, a real library when people are not speaking and just reading. That's 35 decibels. And 65 decibels is the sound of our office. So the sound recommended in the NICU is just above what we have in a library, around 45 to 50 decibels. It's basically the sound when someone is talking to you very quietly. That's this kind of noise. So this is the sound that's recommended to a NICU. And basically the levels that a NICU usually reach are close to a train station. So very high, right? So we have to be just careful because we just do handovers in front of the baby's bed, to talk to parents, you just find a friend in the NICU and you discuss with them. This should be really avoided. And this does have an impact to all the babies. So tapping in incubators is also something that people do, and it's supposed to not supposed to be done. Basically, when you tap in an incubator, you create a resonance of noise inside, and it's an enormous amount of noise that the baby receives. Also, of course, we need alarms, but we just have to be cautious that the alarm noise sometimes is also deleterious. So we can reduce alarm noise to levels that we can hear. And also not let alarms, sometimes in the NICUs, you can see people just leave the alarm sounding forever. They don't do anything about the alarm. And well, this is a security risk because you just become so used to the alarm that when it's real, not respond to it. But also it increases a lot the noise in the unit. Speak quietly near the bedside. So this is a main message here. Light reduction. So ideally, light should be adjusted to the needs of the infant and the staff to provide care. We provide diurnal light variation whenever possible. So if you have lights in your NICU windows, they should be open during the day, but not letting the light directly inside the baby. So we are avoiding direct light, but recommending indirect light, but real sunlight, your daylight whenever possible, but not direct. And on the other hand, if the baby is sleeping, we should avoid lighting on the top of the baby, because especially when it's excessive, because basically contributes to sleep deprivation. We can use cot covers. A cot cover can be just a sheet, a normal blanket. Just have to think about IPC, that they are clean. But a cot cover can shield the baby from bright light. And it can be done for monitored babies, basically, if the baby is monitored continuously. If a baby is sick, it's not monitored continuously, you shouldn't cover the cot because you cannot see the baby. And something might happen that will not be seen. Staffing practices. So this is extremely important. It's a teamwork. So if one nurse comes and does something, or only one doctor will do, pay attention to the baby and the other ones won't, this doesn't make a change. So we need to provide continuity of caregivers whenever possible, promote consistent developmental care practices through the whole team. It's a teamwork, and the baby is receiving messages for everyone. And DSC is not expensive. There are core low-cost interventions like KMC, reducing noise light, clustering care, parental involvement. So low cost actually reduces the cost. Positioning, cue-based handling, and reducing stress, minimizing pain. DSC does reduce length of stay. So these babies stay less in the hospitals, they gain weight more, they improve breastfeeding, they have reduced stress, so they have better neurodevelopmental outcomes, and it also promotes parental well-being and bonding. We do have DSC job aids. So we have a job aid for DSC that has 5 pages. So the first page is the one that we saw of the do's and don'ts. The second page is talking everything about containment, how to prepare containment of a baby. Then we have the nesting, how to prepare a nest, how to build a nest for a baby and make sure that this nest is adequate. Then we have swaddling, how to swaddle a baby safely. And also have a note for transportation, how to transport a baby in a respectful way. Of course, ideally, it should be on KMC, but if the baby cannot be transported on KMC, there are also other ways to do that. So this is the first picture. So we're arriving to the end of this. And this is the first picture that I showed in the beginning. So it's better. So just maybe read what was said in the chat. If there are other Other informations. First baby is flat, lying without a nest. That's true. And the second picture, the baby is nested. That's correct. And I think that's all. Yeah, I think that's all. That's true. So the baby was not nested here. And you see that the baby's arms are flat and falling. This baby will not be able to touch his own face, will barely be able to move. Also, the head is falling behind. And you can see in the second picture, so that the baby is nested. It still could be better, right? So this happened in Cameroon, is in one facility that we visited. All the babies, they were like this. And it was a nurse training, basically, and DSC was part of it. And when we changed the position, and one of the nurses of the training changed the position, she was so happy because actually the baby stabilized. Clinically, the baby was more stable on this position than on the previous position. And you could see that the baby opened his eyes and he was back, basically. The baby was back. The nesting could be better. So the nesting could take also the feet. We can see that the legs, well, they are flexed, but they don't have support. So ideally, we should give support also to the feet, so they can, if the baby dysregulates, if the baby goes in hyperextension, the feet will have support, and the baby will come back. Basically, it will help the baby self-regulate. Full-term babies, they do self-regulate. They do that by themselves often, not when they are very sick. But preterms, they just can't. So nesting would help this baby more if we also had here. But we had a better nesting. We had some nesting here because this baby only had this sheet. And we can see the baby's in a symmetric position. The baby can move this arm, and the baby's, oh, look at the hand. The hand is closed, and the baby can touch the face. So the baby is moved the arm, basically in the direction of the face. So this baby is back, basically. So if we do some basic math, of everything that DSC is, parental involvement, positioning, providing cluster care, sleep protection, stress and painful procedures, reduced feeding support, staffing practices, touch, sensory environment. If we put all of this together, I didn't speak much about also smell and taste. Taste a little bit about the taste of the breast milk. That's also sensory experience, but also the smell. It's also a sensory experience. And there are some studies on the smell of breastfeeding, the smell of the mother. This also improves bonding, and it's a stimulation to the brain and may affect also development. At least it's a positive experience. So KMC, the only thing that it doesn't do is the cluster care, basically, because the cluster care is something that's provided by the healthcare providers or the mother, but it's not in the continuum of KMC. But all the rest is done by KMC. So if you need to implement basically something that will enhance developmental supportive care very fast and also reduce mortality and infection and improve development and all the other benefits, KMC is definitely the ultimate developmental supportive care. So just last slide. So a recap, you see that after all of this information, every interaction that we do to a baby shapes their brain. So we have to have this in our minds. And if you have this in our minds, we have achieved something, basically. Observe the baby before touching the baby, very important. Protect sleep, extremely important. We have to have in mind that we have to reduce stress, and stress is very deleterious for the brain. Support parents is primordial, it's essential, it's paramount. Parents are extremely important in the baby's life, in the baby's development, in the baby's future in the society. Basically, they need to bond, but also parents are very helpful in the cares and in the continuum of care of the babies. Individualized care, each baby is different, even if one would say that they might look the same, that all preterms, they have the same diseases and have the same complications. They are not the same. They don't have the same diseases. They don't have the same complications. They are all different individuals, and they all have human and children rights. Neuroprotection starts with routine care. So implementing in routine care, one by one of these actions do protect the brain of these babies. And again, KMC is the ultimate developmental supportive care. Thank you so much. So this was my last slide. We have some time for discussion now. So I wanted to know if anyone has a question. I can see the hands. So yes. Any questions or comments? There was a hand previously, but I think I missed it. I don't know who was. You're very quiet, maybe overwhelmed. Or maybe you cannot hear me anymore. Can you hear me?
We can hear you, Flavia.
Yes.
Yes, we can hear you.
Marian, do you have any comments? This is extremely, it's also your domain. So would you have any comments, anything to add?
We'll first, thank you so
Professor
much,
Manan.
Flavia. I think, yeah, we'll wait for their responses first. And yeah.
I think I have Professor Manan.
Yeah, thank you very much, Flavia.
Hi.
Excellent presentation, covered everything. Thank you again. So I put some question in the chat box. Would you please see the question in the chat box?
Sure. Let me go through it. Okay. First one is how mother can ensure Q-based care. Then how to ensure limited sound and light in NICU where so many machines are running. That's true. Fear of infection if parents get frequently entry into the NICU. Challenges to implement development care in low resource countries. Yeah. So I will answer what I can. I think there's some things you would know better than me. How mother can ensure Q-based care? That's a very good question. And that's why we prepared that DSC. That it's basically the beginning of how staff can help parents to understand their babies, basically. So I would say that first staff needs to understand what's happening to the baby, and then they would teach the parents. So nurses, doctors, they should explain to the parents how to understand their baby, when to talk, when to intervene, when to do cares to their baby, but also how to take care of a preterm baby, which is not the same. And this is what we see very often. Most of these moms, they are not on their first baby, and most of them had full-term babies, and they treat their babies like their cultures demand. And this is not the same way for a preterm baby, not very often. So there is a way of taking care of a preterm baby, and we can basically, I'll just share my screen again. We can basically go through this with the parents, explain to them that a preterm baby it's more vulnerable. It's more vulnerable to stress, has a developing brain. We can show them that the baby don't know how to talk or communicate, and they will have a behavior that's different than the previous baby that was full-term. We can teach them with this to tell them what's our stress signs and how to recognize. And then we have these pictures, but this can also be shown by the nurse or the doctor. When this is not just supposed to be given to the parents, it's supposed to be explained. And then we have here, how can you help? So how can they stop the baby from being stressed? How can they help the baby to regulate? And how they know that the baby is better? And this should be done basically while the baby is in the facility. So they can ask for support if they need, basically, if they don't understand or if they had a doubt. Staff should be open basically to teach parents. And once parents know, they would also teach the other parents. And this will basically become much easier for staff. And well, when we have a baby on KMC, this happens much less often. So these are things that we're also supposed to tell to babies that are on KMC, and also tell danger signs and tell babies parents how to care of their babies on KMC. And for that, we have the KMC guide. Hope I answered this question. Limited sound and light in the NICU and how many machines there. There are things that we cannot avoid completely, but we can minimize as much as we can, right? We have to make an effort. And that's what I was saying. The way we speak in the NICU is really, really loud, and we just don't realize. And then sometimes it is this in different settings, it happens everywhere. We arrive in the NICU and people are handing over, and just one people starts speaking loud and the other cannot listen, and they speak even louder. And people just speak louder and louder and louder, and it's very, very noisy. So we have to be conscious of that and feel safe enough in our hospitals. So we need to have support from the mentors and from the facility itself to feel safe enough to tell our colleagues to speak less loud, basically. And well, when the machines are running, we just need to pay attention for the alarms, that sometimes we leave the alarms so loud, or sometimes we just don't touch the alarms. The alarms are just alarming there, sounding out loud, and nobody's doing anything about them. So this can also be avoided, for example. Fear of infection. So this, I think the best response for that is KMC. So parents, they are protective for their babies. KMC reduces the late onset sepsis. So this would be the best answer for sites when they talk about fear of infection. Okay, let's start KMC. This does reduce infection. And challenge to prevent neurodevelopment, okay, in low resources to implement. So I would maybe let you develop on that, because I think you know that better than me. But again, most of these cares, they are low cost or no cost, especially KMC. So there are challenges that are inherited to them because we are so focused on the hardware, on the hard technology. But as I say, for example, this baby in Cameroon, when we do it, the staff, they see immediately the change of the baby, and it's so satisfying that when it starts happening, nesting, positioning, containing, when you see babies regulating, it's so satisfying for staff that usually they tend to adopt. So I don't know if I answered as best as I could. I don't know if Marion, you want to add something, or Professor Manan, if you want to add something on your comments. And thank you. These are very good comments. Very relevant.
Yeah, very, very good. Thank you. I think you've answered everything, Flavia. It can be challenging, but the idea is to basically recognize that this baby would have been so comfortable in the mother's womb and just came early. So how can I make the comfortable environment external? So if I'm aware of that, I mean, because the womb is such a comfortable place, it's dark, it's quiet, it's comfortable for the baby. So think of that. And every time we see a baby in the NICU, how can I make this baby feel, especially a preemie? How can I make this baby feel like the baby is in the womb? So, and then you will be able to innovate. And I think if as mentors, if we can might be give that message to the nurses who are primarily with the babies 24/7, and they understand it, it'll be so much more easier. Over.
Yes, thank you, Marion. That's a very good point. Any other comments? We are on time today for our last seminar. We still have 1 minute. Oh, now we are on time. All right. So I don't know if is there any mentor here. I saw a dealer entry, but I cannot see the names. So is there any mentor here that was last week with us? I'd love to see your faces. And I can see a lot of SSNC leads. It's really good to see you here also. And also the master mentors. It feels almost sad. It's our final seminar.
Dr. Ide is there.
Ah,
Dr.
there is
Ide. Adila is there. Amreen is there. I can't see. Okay, let me just see other names. Anyone from your experience, or is this something not practiced? Dr. Kaleem?
Say this one.
Right.
I can't
So,
make out anybody else.
yes. So I think it would be great for this final seminar if we could put the cameras and then we can make a screenshot of our final session. If you cannot put your cameras, of course, I understand sometimes the connection is so complicated. Okay, you have some cameras coming up. My gallery on. That's great. Hello.
Hello, I heard someone taking my name. It is Dr. Kaleem here.
Hello,
Yes,
Dr. Kaleem.
Dr. Kaleem.
Hello, how are you?
Recognized you, so that's
How are
why.
you? Nice to
Just
see you.
wanted to check whether you have any comments.
Mama. Mama, good afternoon.
Hello, good
Prof.
afternoon. Can you put your camera, Otto?
My front camera is bad.
It's bad. Oh,
Yes,
gosh.
I'm about to fix it. That's why I can't put it on.
No worries.
The class
Hi,
was very
Salma. How are
interesting.
you? Hi, Dr. Ray.
Dr. Ray.
Hi, Flavia.
Hi, hi.
Hi, how are
Hi,
you?
Marianne.
Rosina is in the house. Hi.
Oh, hi, Rosina. How are
Oh,
you?
nice.
Yeah, well done.
Thank you. Nice to see you. Oh, to hear you. Great. So thank you so much, everyone, for being here. We are going to upload, for those who could not come, in our website, and we are very, very close to the start of the mentorship. So all the best for the mentors. I hope you're going to meet personally again, that we're going to have online meetings again, probably. And I'm looking forward to see all the success of your mentorship. And thank you all the SSNC leads also. Yes, I'm going to have a training on strengthening tool, and also looking forward to that. And I think with that, I don't know if you want to say something, Marian, but otherwise we could close the session.
I just would like to thank you, Flavia, for this session. Great session, lovely videos and PowerPoints as well. And thank you, all of you, our wonderful mentors, as well as our SSNC leads and the rest of the research team for being present. Do let us know how you, this one, how you found the webinars and different aspects, and how you would use these webinars to really support the healthcare workers in the facilities that y'all will be mentoring. Over to you. And thank you so much. We'll see y'all again sometime online or might be offline too. Over.
Yes.
Thank you so much.
Thank you.
Thank you. We appreciate the
We'll
lecture.
be
Thank you.
sending you some
Great.
emails. Yeah. Thank you so much. Have a great day.
Thank you.
Bye.
Thank you, Flavia. Thank you,
Thank you,
Miriam.
Dr. Flavia. It was an interesting
Welcome.
presentation.
Thank you.
I've
Bye,
learned more
Eddie.
today.
Thank you. Thank you.
Prof.
Bye.
Heidi, well done,
Thank
ma.
you. Thank you, Otto.
Amina.
Dr. Otto. Thank you.
All right, ma.
Thank you so much, Dr. Flavia.
Bye.
That's good to see all the Nigerian team. Thank you. Bye.
Yeah.